Well, good afternoon, everybody. It was just again a lovely morning. I want to thank everybody for their participation and all their time and effort that they put into putting the ideas together, and we're going to get to see them shortly here. This is our last kind of formal session of the day before we go to the reception afterwards that I hope everybody can stay for as well. So, as we all know, we've got a panel session here. It's intended to be interactive. The overview is pretty simple. Our scene setters are going to give us about a 6-minute summary as to what they learned or uncovered or determined in their group. We will then take time I will then have about 30 minutes to talk with the panel with some questions. But the entire time along the way, the audience will be able to weigh in. So you've got this QR code that you can either look on the screen or look at the back of your program. It should be back there as well too. And it's a program called Slido on your web. And you'll be able to answer questions in one of the tabs, and in the other one up there, you'll be able to upload questions that you may have, because for the last half of this panel session, we will let you all ask questions. They will be up on the screen, and we will turn to our panelists to help us answer them. Any questions on that? No? Wonderful. And again, we do want to encourage everybody to ask questions because it's dialogue. It's going to be our way forward here. So before we get to our panelists and our report outs, why don't I just ask each of the panelists one by one just to remind you of who they are, as to tell us their name and what their role is, and then we will start the session. So Vanda, do you want to start us?
Thank you. And do I need to lean in? Sure.
Or maybe not.
There we go. Hi, I'm Vonda Vaden-Bates, and today I'm here representing Project Pivot, and one of the aspects of the Patients for Patient Safety partner in this day. Thank you. Good to be here.
Hi, I'm Ayşe Gürses. By the time I take this out, I'm Ayşe Gürses. I'm a professor at Hopkins, a human factors engineer, and I am representing the systems design group today.
David Newman-Toker, Johns Hopkins, Director of the Center for Diagnostic Excellence, Neurology, and reporting out from the Diagnostic Excellence Group.
Good afternoon, Colonel Stephen Coffey. I'm a founding member of Patients for Patient Safety US, an active duty military member, and yeah.
I'm Craig Umscheid. I'm a general internal medicine physician by training, and I direct the Center for Quality Improvement and Patient Safety at the Agency for Healthcare Research and Quality. It's great to be here.
I'm Leslie Dureco, physician leader, and I'm the Chief Medical Officer for MCIC, which is a captive insurer of Johns Hopkins, Yale, Cornell, Columbia, New York Presbyterian, and Rochester that work together to prevent harm.
Wonderful. As you can see, we have a lovely panel. Thank you all so much for being here today before we get right to it. All right, Diagnostic Excellence is up first. David, you want to do it from there, right?
Yeah, I think so. First I want to thank the entire group. It was super engaged throughout the entire small group session. A lot of generative, great ideas there. It was generative human intelligence at work. And I want to thank our moderators who were also fantastic. So with that, I'm going to just give you I'm going to start by giving you a couple of themes that I heard sort of iterated on repeatedly. And then I'm going to tell you what the sort of conceptual idea is. And then if I have time, I'm going to tell you a little bit how we got there. So the three of the things that I thought were super important that sort of came up in various forms over and over again. One was we should focus on the patient harms as a goal. Two was we should surface hidden data, especially the patient voice in the whole operation. That the data was crucial, but it was the missing data that we needed, the data that aren't there. And that we should right-size any projects, demonstrations, or otherwise that come out of this. And for a 2 to 3 year time horizon, that right-sizing is probably at the state level and not national. The specifics, people were, I think, pretty much aligned around wanting to reduce harms. I think the 20% was picked as some slightly, arbitrary number, but measurably reduce patient harms for 3 conditions. And people talked about the big 3 a lot. It wasn't just me, and it wasn't just at my table, but but I think it's important to know why that is, and it's because that makes the tent just big enough so that most people feel like they're fitting into it. And if you narrow it a little bit too much, then all sorts of groups splinter away and are less interested. It's going to have to be, I think we should have 3 demonstrations, 1 cancer, 1 vascular event, 1 infection. It's going to have to be some specific thing, right? It's going to have to be stroke or VTE or MI or whatever, but at the end of the day, that's the level at which people can stay committed and engaged to the general construct. There were a lot of things that didn't quite make it on the page because I think we were sort of struggling with the wording and kind of where things went into different boxes. But in essence, what we wanted to do was make sure that these hidden data got surfaced, and whether that was going to be using tools to capture data better, ambient AI, large language models, devices, et cetera, from the sort of ether, if you will, or patient-reported data and outcomes that were related to their experience or their concerns in the process of care, that these were critical data elements that would help drive the success of these kinds of interventions and projects. We talked about kind of where to place demonstration projects, but this idea of a state-level demonstration and maybe having 3 of them was, I think, generally speaking, thought of as kind of the right space. National felt like it was just too big. And that there were some important issues about figuring out how to create the data architectures and repositories and ways of data sharing, whether that was regional health information exchanges or collectives of one sort or another. A lot of clever thought about what would work and what wouldn't in terms of existing regulatory frameworks, et cetera. But we need some architecture for data sharing. For example, if one hospital sees a patient and lets them go, and then they get readmitted down the street, and they never find out that the diagnostic error was made, somehow those data have to be shared back. And some places have that kind of regional health infrastructure, like CRISP in the state of Maryland, and other places don't. That we really needed to latch on to the business case and a return on investment, that at some level, the notion of engaging payers as part of the mix in order to be able to encourage the adoption of innovations was a crucial piece of the puzzle. And we had to be sure that our outcome measures really reflected things that we cared about and that were attainable as measurements. And I think often talked about patient-reported measures in that light, and measures that we already capture, like using administrative data or other things that we can mine data using techniques that have been developed. I'll just take one moment in the waning moments to just float a couple of the ideas that came out. One table came up with the early warning system for diagnosis, with the sort of panic button or the fire alarm that the group could pull. Another wanted to deploy LLMs at every level of the healthcare system, from kind of the patient level all the way up to this sort of meta monitoring data and information level, and leverage that to kind of move us forward. Our group focused on the idea of the big 3 for demonstration projects, and the 4th group talked about cutting harms for the big 3 by 20%, using a mix of technologies and registries. So thanks again to the group. I hope I didn't misrepresent too much from today's discussion, and I'll leave it there.
Thank you for that, David. And again, what we'd love people to do is, if they have additional thoughts or reactions related to diagnostic error, take a moment to, this poll should have been opened, right, as I did this, as I clicked on it. So you should be able to just put them in right now as well, okay? You want me to wait for them, or should we? So why don't we do this in the interest of time? As people type them in, you'll actually be able to see a few. We can take a minute to do this. Or what we can do is just let people type them in and we can come back to it at the very end. Because I think typing is going to be harder to do, right? So we'll come back to it. All right, so we're on patient experience. So Vanda, you're up next. You can do it from up here or there, wherever you're most comfortable.
Well, we'll see what the group came up with, because I actually haven't seen it myself. So, and we did some very good word crafting. It was a great group, great facilitation. Thank you very much for the whole team. I will say just a few things that stand out for me, and then I am going to literally read, because we were very, very careful with almost every word, and I definitely want to try to represent the full spectrum. It's very clear that when we talk about AI, that we're seeing it through the lens of our current environment. And so I think that's one of the pieces that's a struggle right now with trying to really imagine the patient experience and how to use patient experiences in real time, and also use past data or experience harm. So, goal is to prevent harm. And one of the ways we do that is to, in real time, get it right, make it easy to make the right decisions and hard to make the wrong decisions. That's based on past data, but it's also based on the existing experience of that care team in place at that time. And so we toggled quite a bit between those different environments and how you bring those together, and the promise of AI, but also not the only technology being deployed to help bring us to what I think we've got to, is pursuing zero harm, knowing that it's a journey, especially when you are using stories, experiences, and outcomes, and measurement data, and evidence-based practices, and you're adding to that list all of the factors. And AI, I think, will do a great job of bringing that into focus for us on behalf of the delivery of care in real time, as well as the research that will help feed that. So our goal ended up being pursuing zero harm and optimizing patient experience through patient and family engagement, measurement, and shared learning to co-create clinicians' transparent and fiscally and emotionally safe health care. So that ended up being our goal. We talked about a number of things on the development side. One was really leveraging those LLMs and artificial intelligence, advancing the technologies to implement those evidence-based practices, but then also integrating the patient experience in a real capture tool. So what does it look like a year from now, 2 years from now, 3 years from now, when you walk into that hospital, and like I was in 2012, completely naive. I hadn't studied patient safety. I had no need to until that moment. Maybe we're given a tool, a device, and on that device is something that is also a chat that's going on with the care team members and the clinicians and lab people who are coming and going. And maybe that real-time data is also feeding into a larger model. I do want to really make sure that we talked a lot about accessibility. LLMs, AI has there's a risk involved that becomes monetized, just like the healthcare system itself has. How do we make sure that that accessibility with AI continues to be accessible to absolutely everyone, whether they're entering that care system as a clinician or as a patient, a family member like myself? Deploy that AI tool then for real-time feedback analysis, service gaps and trends. Use best practices to identify and respond to patient harm, those CRPs, and also make it human. We talked a lot about trust. And it was very interesting. I think we had 4 or 5 tables, and almost every single table, the issue of trust came up around AI as a tool. As patients, sometimes we may not necessarily go in wanting to give our information. What will be done with that information? There are very valid concerns there. But it also is I heard one person say, they were imagining that somebody's given an iPad and you're supposed to fill out these questions to give the AI, begin to engage. What if it's actually just on a telephone? So we covered the gamut in terms of what that engagement might look like with that tool. And then financial incentives were very interesting, and I've got 1 minute left, so I'll start to close on that one. I'll leave with the one idea that I thought was very interesting is to have patients be incentivized to actually engage with the AI tool. And what would that look like? Maybe it's changing co-pays. We didn't necessarily get into payers and all of that ring, but there are probably a long list of ways in which we can begin to find incentives, both on the clinician and the healthcare system side, but also on the patient side. Thank you. And I'm sorry if I didn't represent us very well, but that's as close as we can get in this first iteration.
I thought you did a great job for what it's worth. We can take a moment. The poll is open, and we'll keep it open for you to provide your thoughts on this too. Just give you a moment. Oh, so we're going to let people, on this one, they get to vote, huh, on the strategies. So as you can see, you have the ability to vote on this one as to ranking them. And again, we'll let you do this as the next, as we continue on this, because it can take some time. All right, Aisha, last but not least, you're going to come up here?
Yes.
Okay. Okay.
Because my team, it was absolutely fabulous. We created so many ideas. I cannot keep them up here, so I need to see them. So in terms of systems design, our goal was, after each of the teams had different goals, we collaborated to come up with this goal, which is create a knowledge-based and human-centered operating system that captures harms, successes, and innovations to empower patient collaboration, zero harm, and human thriving. So we do understand that we do capture some of the harm data or the adverse event data, but we wanted to also capture the successes and innovations, and I will put their strategies also more systematically. So in terms of the AI portion of the intervention, the few things that came up were, one of the concerns was how to, or opportunities, how do we measure and analyze current AI models' performance in healthcare? How will we evaluate these proactively or even during implementation? Yes, we have some responsible AI type of frameworks, but they are still at really high level, not being operationalized enough. Sorry, so I'm inserting some of my own thinking. So if I don't agree with you, team, please. That is common that people don't agree with me, so don't worry. And tell that I am misrepresenting. So some of the others are, how do we develop trust in AI, the clinician AI or patient AI trust? And what does it take? And is trust something that is like built and that's it? I now trust to the AI forever? Or is it something more of a continuous thing, etc.? How do we leverage existing data to improve healthcare? But I have also heard, which also I agree, how can we collect data using, our environment, more like sensors type of thing, rather than putting data, like manually entering the data, etc., from EHR. So how can we use data, sensor data, or those types of data to really build algorithms upon, basically. So those were under the first one, the AI one. In terms of the second one, implementation of best practice, operational knowledge to action one, we actually disagreed with the instructions a bit because, and it's not only me, we actually discussed a lot what best means. You know, we had engineers in the, other than me, some engineers. What does best mean? They were also saying, and I felt so happy to hear that because, you know, what does that best really mean? Did you like do an experiment, etc.? Or is it really a few, like not a few, but it's based on expert opinion, limited data? And maybe we couldn't come up with the perfect term, but we just wanted to acknowledge that because sometimes we call it best practice and we think that that is best practice and we make people accountable. Oh my God, 2 minutes, okay. We tell people best practice and everybody tries to follow that and it becomes a problem not to follow. And I have actually experienced this a lot in some of my CDC research. What is a protocol, guideline, policy, etc.? Currently, not many of them in the hospitals, healthcare systems are actually supporting the work. They are there so that the hospitals are protected and there is some, you know, we protect against malpractice, suicide, etc. But it is really not supporting most of the time adequately the cognitive work of frontline professionals. Anyway, so because of time, I'm gonna just read and not think. Prototype. Prototyping an optimal care delivery system and developing a database of harms, errors, and innovations. Under C, aligning incentives, reimagining these HCAHPS type surveys, patient satisfaction surveys, and some of these, what is this, all these abbreviations, with value-based care models, incentivize basically incentivize DOX on whatever DOX is, it DX, on increased value-based care models and innovation funding. So we did talk a lot about developing a return on investment, really showing the value of incorporating systems design and as a result, patient safety into healthcare. In terms of the policy and oversights, this is some of my favorite ones. Mandating HF and systems training at all levels, truly, and making, and some of it, my insertion, you know, how to incorporate, how really healthcare executives think about systems design as part of their daily lives, as opposed to only firefighting every day. How can we really make system design, redesign more part of the healthcare executives' jobs? We have also talked about, you know, how to include it in a more standardized and effective way in educations of the new generation as a part of licensing and other programs in a more effective way so that the safety science and system design principles are already integrated from the beginning of their career. Thank you.
Great. So I want to thank all our panelists for those quick summaries. I know it's not easy to do on short notice, but it was awesome and it was a lot of great work. So what I want to do is we have about 30 minutes now for some questions. I will start with a few and then we're going to open it up to the audience. So let me start with our three panelists who did not present yet. And I can tell you that I noticed that from when I went and had a chance to go sit at some of the tables, there were a lot of great ideas that people were putting out there and people were discussing and trying to figure out the way forward. And to me, so a lot of good ideas is great, but how do we come to agreement often becomes a challenge. And as I look at the three areas that we've picked today, right, diagnostic error or diagnostic excellence, why am I drawing a blank now? Patient experience and human factors. I was shocked that no one came up to me and said, Alan, where's infections? Where's med safety? Where's communication and resolution programs? Or where's falls? Because we often talk about these events that happen all the time in hospitals. What is your take? And Leslie, we'll just start with you because you're on the end there. Because you've done this work, you've had to deal with it in your system. What is your take on I'd argue that the three that we've picked are very reasonable, great places to start. Although AI did cross all of them, you could argue it's AI as well. But what is your take on the list that we have, or how we prioritize in what we pick to kind of go tackle first?
Yeah, one word, relieved, that we weren't talking about the same metrics that we have been talking about. Not that we should undermine, that harm is important to solve for. But this, just to have patient experience in that top three, really, really important, and probably the reason why we haven't solved as far, or haven't come as far or fast as we needed to, because we haven't prioritized that as much. So I was relieved about that. I was relieved that AI was themed through it all. I think from the healthcare system lens, we're all trying to figure out how fast to go on that. And I was reminded when I read something, it's, if you do it and do it well, the patient is grateful. If you don't do it and don't use it, the patient, you can't win in the AI world right now. And so I was grateful that we're thinking about that to kind of pull the data together and solve. I love the idea of ambient AI listening for harms, but more importantly for successes that we can tap into and learn fast from. So yeah, I was relieved by the topics.
Excellent. Let me jump in on it really quickly. And so, one of the things that I think about is that when we talk about the goals that we have of getting safer and more quality and more inclusive care, it's a very lofty goal. But the reason why our goals don't always come to fruition is because we don't have the right leverage. So when you have that right lever to kind of pull and make things happen, then we have things that happen. So I think one of the levers that we often overlook is really that voice and the injection of the patient as part of the solution. And I say that because when we look at things from a clinical sense, and I'll tell you, here's my military example of it. If I see everything as a problem that can be solved with a 2,000-pound bomb, then that's how I'm going to solve that problem. But when I look at things and say there are other ways, there are soft skills that I could use, there are patients' data points that I can use to solve that problem, then we make meaningful change. And I think fundamentally you have to always remember that medicine has always been and will forever be a people business. And at the center of medicine is that patient. And so when we have that focus as our guiding light, our North Star, that we want our patients involved, we want their voices heard, we want to use their data points as part of the diagnostic process, we have safer care, we have more equitable care, we have more inclusive care. And so I really think I was very happy to see that we had patient experience as one of our topics. And for me, as a patient advocate, and dare I say a patient activist, who doesn't just use a voice, but really wants to put action behind that voice, is a very important thing.
Thank you for that. Craig?
Yeah, I thought this concept of amplifying the patient voice and finding opportunities for patients and families to share their concerns, it was a theme that you heard throughout, not just patient experience, but diagnostic excellence and systems level solutions as well. I think the other areas that we spend a lot of time thinking about at ARC are workforce safety and well-being. A lot of what keeps, I think, many of us up at night is thinking about how challenging it is for the healthcare workforce to provide safe, high-quality care for patients, and how to build systems and build culture to make it easy for them or easier for them to provide the care that patients need. The other area that we talk quite a bit about is culture and leadership. Oftentimes that brings in healthcare administration, but I think so often it's tough to move any of these forward without that leadership at a systems level.
Great, thank you. So, Steve, you just mentioned something about levers and we want to pull. So, David, if we were to pull up the levers that you had talked about, or the ones that were given to you all in the areas, right? One was AI, another one was doing a better job with knowledge to action, another one was financial, another one was the policy piece here. what would you say is the most effective one that would be most effective in the diagnostic arena? You better say patience.
I'm watching.
So I think for a lot of reasons, patients rise to the top. And I'll be specific about that so people don't think I'm just playing into the going theme. I think Stephen's point about the whole issue of using patients as leverage is really significant, because patient voice from a kind of a policy standpoint actually is what matters. Enough people run into somebody's congressional office saying, this is important to me, this is important to us. That's the coin of the realm in politics. So I think that's critically important. But I think what we heard today is that patients, not only do they deserve to be engaged and that they want to be engaged, but they also have the data that we need in many cases to be engaged, including, but not limited to, their initial symptoms and problems that need to be elicited, and they need to be part of that conversation. Their sense that something is wrong, that's being ignored, that they need to pull the fire alarm or push the panic button. Their knowledge that the diagnosis changed 3 weeks later or 3 months later, and there was a diagnostic error that happened. So I think ultimately that's where the kind of epicenter still is for me, even if you get into not just in an emotional way, but in a logical way as well.
If I could just push you a little bit more, David, on this. If there was one specific action you would do to amplify the patient's voice, what would it be? And that's a hard question. Don't get me wrong. I mean, it's what we're all grappling with.
I do think if you want to get super narrow about it, I would say the ability in real time to report what's going on.
Okay.
So whether that's, I think something's wrong, or somebody didn't listen to me, or there's a symptom that nobody elicited, or something new just happened, because that real-time data is only going to come from the patient, and in most cases, and that's the earlier we can push the identification of that information and surface that hidden data, as David Rastel called it in our group, that is the way to leverage all these technologies as a secondary benefit.
And I think one thing, really bumper sticker for that one, it's partner with your patients. It's absolutely treat your patients not as just consumers, but as partners in care. And that's how you get after every single thing Dave talked about.
Wonderful. So Aisha, can I ask you a question now? So, I personally think human factors is one of the most important pieces with regard to getting it right in quality and safety, because it has to do with design. We all get it. Yet when we often go back to our jobs, it's not what we see in front of us. What do you think has been the barrier to getting human factors and design into our everyday lives the way we would all advocate for?
Yeah, I think there are multiple. It's not only one. We can be bold here, right? We need to have HF-trained leaders in the hospital. We are still happy if we have 1 or 2 HF people in the entire health system who are sometimes, and people are like so happy. These hospital presidents come and say, we hired a systems engineer. I'm like, okay. Really, think about it. It is all systems design. I know it is not as tangible as, let's implement this AI, or let's implement this. We have this leader doing this leader. Those are needed also. But we really need people who understand HF and system design on, leadership levels in the hospital, supporting this type of work. So 2, we need to I think, provide our existing leaders time, space, and some additional, probably, coach training on this. But mostly time and space, so they are not like firefighting all the time. So not that they cannot do, but we need to accept that just like a physician, I can try to operate on someone. There is a science behind human factors and systems engineering. So we cannot really try not to see it because it is a bit, doesn't look like, okay, today I took care of 20 patients kind of thing. It is a bit less tangible. But in the long term, it will be if you are making the right decisions and make the right system design issues. I can give you a very quick example. So when we went to 5 cardiac surgery centers as part of my study, this is just an example, large cardiac surgery centers across the nation, 3 of them, we are studying care transitions. Again, AHRQ funded, thank you. We are studying care transitions, and IV pump brand A is in the OR, and when you go to ICU, it's another brand of pump in the ICU. And there is a resident, and one of the residents' responsibilities, surgical residents, is to make sure that brand A pump gets to ICU, gets switched to the B type of pump, and the resident is responsible to get it back to OR. Talking about value in healthcare and risks, and this is a post-op cardiac surgery patient. And when you ask people, like, why are you doing this? Like, because finance or leadership decided on this. So these types of things, like human factors people, I think, again, not that I am biased, but needs to be really in front of most of these decisions. You know, how are we gonna purchase the system of systems thing? How are we really redesigning toward that system of systems thing every day, little by little by little? So, yeah, do you need more?
That's plenty. You're actually giving me some flashbacks to, I was not a cardiac surgeon, but memories of things I had to do when I was a resident, so I totally understand you on the designs piece. So, Vonda, your group had talked about AI. That was one of the things that you'd pointed out. But I just heard Leslie say at the outset there that with AI, there are a lot of patients who are not happy, even if you do it right, or if you do it wrong, they're not happy with you. Did your group talk about that? And what are your thoughts on that?
We did not talk about that specifically, but we did talk about the levels and the variations of engagement with AI. And I do think that there is a way in which AI is going to have this capacity to meet people exactly where they are. And that's what our group did talk a lot about. It can, engage that person who feels nervous in a different way than that very, very confident clinician who thinks that they don't need support with all of the AI data that has, culled all of the details around those particular body of symptoms that might just be something rare or something very common. So I think the flexibility with AI will hopefully address some of the concerns that you've raised. It's certainly not a be-all, end-all, and we're not going to stop it. So I think one of the things we have to grapple with is that it's here, it's happening, and whether you're a patient who embraces it fully and is already using it daily, or you are a patient who has decided you are never ever going to use it, it's like internet. I think about all the things that we 10, 20 years ago thought would not be universal, and today they very much are.
Excellent, thank you.
Can
David,
I,
think you
can
wanted
I
to
ask
add to
a
that?
brief follow-up question of Vanda? You said before that there was some discussion and concern about monetization and accessibility of some of these technologies, if I remember right. Could you just talk a little bit more about where you think the group and the patient perspective sits around the issue of commercialization to get to scale? Because we have this conversation all the time. We do something in an academic center, it's great, and we can't get it out there at scale. And we need to talk about industry and money, and then everything breaks down because people start getting worried about commercial interest. Could you just talk a little bit about the patient perspective on that dilemma?
I think patients who are in the know, who have had experiences, look at it probably very differently than an average patient who has not had a direct experience of failure. And I say that because there is there's this dynamic of everything is going to be commercialized. I think as just humans, we've kind of gotten used to that idea. And I also hear, though, over the last 13 years, everyone, clinicians, researchers, you name it, the entirety of us here together today, does not want to compete on safety. And so I think we in this room have to lead how we don't compete on safety, but also how we don't have AI compete with AI. It has to be accessible immediately. It has to be relevant to the multiple levels of systems. And there's a way in which I hear various concerns, and they're all very valid concerns. However, if we don't determine very early on that the LLMs for medicine, for healthcare, are going to be universal, I don't know how you get that back. I would go to the policy level for that one.
All right, so speaking of policy here, that was one of the levers that was included in all the groups, but this is an open question for the group here. And I'm taking this from what the audience had put out here too as well. What regulatory barriers do you see that exist today to us moving safety forward? Are there any that need to be removed? Especially because we're going through an era where our government is actually considering removing regulatory burden, right?
I have to say, the one thing we didn't talk about today, except very briefly, I think Stuart alluded to it, is this separation between research and clinical care is a disaster. Because basically what it boils down to is they're two completely different pathways for thinking about things. There's no such thing as a learning health system because if you actually, research is where you try to learn things and you share them with the world and you scale them. And clinical care is where you promise to be sloppy and not to learn anything at all, right? And otherwise it's research. And I say that glibly, but the truth is that that's kind of how the whole system behaves. And I think that is a major problem for actually getting to the point, especially when you're talking about stuff that is in this, gray zone around quality improvement versus quality improvement research versus health services research versus quality research. I mean, it's stupid. Patients don't, if patients actually out there knew the hoops that we had to jump through for months and months and years in order to do just the most basic, simple things, they would be absolutely shocked and offended. It's unbelievable what we can't do to help them, to do better by them because of this kind of regulatory environment.
So Craig, I mean, this is your job in a way, right? You're looking to bridge that piece. You're actually looking to create more research to improve clinical care, right? So we'd love your thoughts on this.
Yeah, I don't disagree with David at all. I do think there is a role for national decision-making around standards, around measures, around data interoperability. But I do think if institutions are dependent on federal dollars or extramural dollars to make the systems changes or the improvements or support the staffing or the workflows that they need for high-quality, safe care, that's a mistake. And I think part of how we could do better as a safety research field is helping healthcare institutions, healthcare leaders better understand the return on investment around safety and quality interventions, and make it tangible. Not necessarily these interventions deployed at a national scale would save, this number of dollars at a national level, but these interventions deployed at an individual healthcare system of this size would save a healthcare system this number of dollars, equivalent to an EHR implementation over the last year, or a new building that you want to set up. So really demonstrating the tangible savings that investments in safety and quality can help them realize.
I love that idea. But do you think that will overcome the problem of scaling that we often hear about? Because we see this a lot. Somebody will do a great study or a great analysis at their local organization to show that something worked. In fact, David opened with that a little bit with teledizzy as we've been trying to scale. How do we overcome that barrier of scaling? Because I agree with you. I think you need to make the argument at smaller scale and study. But how do we, and again, this is what this meeting is about. How do we get that scaling to occur? What do we need to do there?
Yeah, I liked David's example earlier of the diagnostic safety work, doing a state initiative around one of the big three diagnostic errors and demonstrating, what a bundle around, let's say, addressing sepsis at the state level or stroke at the state level, what a bundle implementing that across the state could help the state realize in terms of improved outcomes for patients and families, improved healthcare savings. And we saw that with the Michigan example 20 years ago with CLABSIs. And what happened with that, obviously, was creating a new standard and helping us realize that CLABSIs aren't just part of, doing business, but they are actually preventable. You can get to zero. For diagnostic errors, we're at the point where, we do lament the impact we have, but how low can we actually go? So maybe we can do a demonstration project to demonstrate that with the right approach, we can get low. Creates a new standard, and that standard can become a measure. It can become something that a healthcare system can be held accountable to. Obviously, there's a whole medical legal system across this country that holds healthcare systems accountable beyond payers like CMS or local payers. So I think part of it is demonstrating what the standard should be, and then relying on healthcare systems to adapt those standards to their local setting.
So I want to take a slightly different approach because we're in DC, and so before I got into healthcare and that type of thing, I was very into politics. And so Tip O'Neill, former Speaker of the House in the 80s, said all politics is local. And I translate that to medicine to say that if we were to get some of the biggest health system C-suite leaders, right? I'm thinking of like on a global scale, we have like the G20, the 20 most countries. If we got the biggest healthcare system leaders and they all got into a room and said, this is what we need to do to focus on safety, that's how you start to that's how you scale it. Because we all have this shared value, this shared vision, this shared objective and goal. And we've done that at Kaiser's, because we had a person from Kaiser in my group, so we did that at Kaiser. We've done that at Brigham and Women's. So if we get those large systems together, those large C-suite leaders together to really focus on that goal, there's a scalability part because we're now doing it with a shared vision and a shared direction getting after safety and quality. And so that's one of those kind of a radical idea, because I think a lot of times, as was mentioned many times through the day, you can do things at the local level, you can do things at your state level, but how do we get it nationally? And it's because we're looking at things in a silo. But when we get those leaders from those large organizations, those smaller ones will generally follow suit.
Anyone want to add on that?
I'll just remind us that was done in the last couple of years. Some leaders were put in a room, and if you listen to that, it was a closed room, but if you listen to it, there was quite a lot of excuses put on the table for why they couldn't do it, couldn't execute it, couldn't spread it. And hey, those of us have been in the C-suite, it's very challenging, and I think it's because of that great divide between theoretical research, practical day to day, and really what the work feels like day to day. And they couldn't come together. It was kind of, I don't know, did anybody else listen to that? It was very disappointing, the healthcare leaders, because of the excuse making versus us being able to give them some practical direction and then maybe take something off their plate to the regulatory part. When we think about systems thinking, we also have to think about thinking at a larger scale. There's only so much capacity. So taking some of the regulatory burden off so we can do translate some of that research into day-to-day practicality would be great.
Go ahead, David. You want to say something?
Go ahead.
No, you.
No, no, and so this probably be a great reception conversation to have, because I look at I look at this from when we're doing, and again, I'm a military person, so I think of things in military terms. When I look at how we come up with strategies and plans, everyone has their own individual thing, right? So I'm looking at those hospital CEOs and those system CEOs, they have their own individual thing. But we come out of a room with, here's what we're going to do, because we have a solid objective that everyone sees themselves in that objective. And so, I'm interested in seeing why, or some of the excuses that were there. But then it goes back to that regulation. And so what is it regulatory-wise that is binding me to not want to think innovatively? What is it that is not allowing me to say, let me include that patient? And so I always go back to patients because I'm a patient activist. But what is it from a policy perspective that hinders me from wanting to actively engage patients? If there was an incentive for me to engage them, if there was an incentive for me to show that I've had higher engagement scores or whatever that would be, then there could be something that turns that tide. But I am looking forward to having this discussion at the reception.
So let me just add to your discussion that you can have during the reception here, because Marty and I, when we were talking, it was yesterday, the day before, he was lamenting the fact that the AHA had put some recommendations out recently. And if you look at them all, and Marty and I went back and forth just a little bit, but he was very kind to me, I would argue they were all reasonable recommendations that had to do with removing some of the regulatory burden that's out there. My favorite one was the removal of the sepsis measure, because it drives many of us crazy. I would argue that's all reasonable. But what's missing from that, and I think this is what you're calling for and what Leslie's saying we haven't heard, what was missing from that was a call from them to say, can you do X, Y, and Z to help us improve care directly? So I guess my question to this group, and again, you were all in your sessions, how do we get our leaders to start talking about the way forward in this arena, in this space?
So,
Did I get that right, Marty? Was I close or am I way off?
No, you got that right, but I'm really interested in this question because we've done this. We've got the leaders together. Craig, you got them together when we launched the National Action Alliance.
Yeah.
And they all said, we need more money. I mean, that was basically it. I'm being very blunt right now. They said, we need more money to do safety. So we've done that. We've done large scale. We've done the Partnership for Patients, which engaged most hospitals in this country and produced results that saved money. But when the funding went away, the project went away.
Yeah.
So I don't disagree about our conversation, but we've done some of these things and it just didn't stick.
I think the fundamental problem in this whole story is misalignment between incentives and outcomes. And in a very complex system where everybody's got competing incentives that are focused on themselves and not on the overall outcome. So, for example, in diagnostic safety and quality, it is abundantly clear that we could save lives and cut costs at a societal level at massive scale. Like, we could save, just on the one silly little dizzy problem in the emergency department, $1 billion with a B dollars a year, right? I sit around clawing to get a grant for 200,000 or $1 million here and there. There is $1 billion being wasted on the table every single year in the United States just for that one problem. And I can't get any money to get this scaled. Now, that makes no sense whatsoever, right? It's good for patients, it's good for doctors, it's good for workflow, it's good for the economy, and yet we can't. Why? Because the people who benefit from that aren't the same people who have to do the work of implementing that. So when I go to the healthcare company, the health system, and say we should do this, I say that's great, but then you told me you're going to decrease waste by cutting out CT scans, and I make money on my CT scans, and now I have to figure out how am I going to offset that loss with some other thing. You know, you made care quality better and more efficient, but it didn't help me. And that's really the fundamental constraint in our healthcare system now. And there may be ways to fix that by changing the way payers pay.
Yeah.
I mean, that's really the key, is like if we can get, for example, a bundled payment around a symptom, and you say, okay, look, you're gonna get $1,000 for a dizzy patient in the emergency department, because that's, you know, the average in the country. And you get to keep the rest if you spend less and the patient, nobody comes back with a stroke that got missed.
Yeah, so David, the problem I think you're describing, I think of it in super simple terms for me. I think about when the new Hep C drugs came out, the oral ones. They were like $80,000, right, for treatment, but you made Hep C go away, and everybody agreed that the downstream benefit was much greater. And the issue is, how do you line up getting people that medication up front, because you know somebody else may benefit financially down the line, even though we knew it was good from the patient from day one. So I want to open this up to the panel here. So in the financial and policy recommendations we saw, were there any that you thought addressed this concern the best? Or do you have thoughts on how to address this concern? Because we often talk about how it's set up to begin with. Yes, Vonda?
I have thoughts. We did not get to that question, but I think there was a question at some point in the program preparing for this that who's missing from the room, and I wonder, you know, who's missing from the room are other industries, even the AI developers who are bringing forward the LLMs that we will be working with. And I think we really have to go outside of even the economic constraints, because the problem that we're describing here is a very same problem for many other industries. And I think we just kind of have to go to the meta level with it in some ways.
Yeah, I think going along that theme, you know, employers are an important part of this discussion. I think we talked about, you know, estimating the return on investment for healthcare system leaders, but I think estimating return on investment for employers in terms of their employees' healthcare and how that drives healthcare systems to respond, I think is really important. You know, we talked a lot about AI today, and I understand the hype around AI and the promise around AI. I was actually surprised at how pervasive the discussion about AI was across all three streams. You know, I'll share, I do voluntary clinical service a few weekends a year, and, you know, when I'm in the hospital, I'll tell you AI is in the back of my mind. It's not a need that I'm seeing as I'm working with residents and students to address the concerns of, you know, 25 patients in a morning or afternoon. It's just not a solution that exists for the problems that arise. So I was surprised by how prevalent AI was. But I do think the EHR is a really important solution and tool. And it can also be a barrier, and I think EHR vendors are a really important part of this discussion. They've been part of these discussions, but I think more and more, if we look to them and hold them accountable for the quality and safety of their products, I think we would be better off as a healthcare system.
I think we have somebody from Epic in the audience, is what I was told. Is that correct? Am I right? Would you like to comment on how you all are thinking about this? And please tell us who you are.
Hey everyone, I'm Sean Bina from the patient experience team at Epic. We are building AI. We have over 200 projects that are ongoing right now, building AI into the Epic system. So everything from generating in-basket messages for physicians to being able to summarize the record for clinicians to being able to automatically do authorization or denial management. So AI is at the heart of what we're working on every day. There's, you know, I think somewhere around 60% of our developers are already using AI to write code. And so it not only happening at the level of physicians interacting with patients, but also at the level of just us engineering our systems, which is creating the ability to move much more quickly than ever before. Going back to the prior question, I think one of the things that could make a huge difference is if we reimburse physicians for communication with patients. So Our primary care providers have really been kind of cut out of the financial equation in many ways, and one of the big problems that we see across the board is all the work that they're doing to take questions from patients, which is exactly what we've all been talking about throughout today, is that we want patients to be more engaged and involved, but then we aren't rewarding physicians for participating in that process. And so one of the things we've been advocating for is really focusing in on that primary care and rewarding physicians for that work.
Thank you for that. So I'm going to we're in the audience question time here, so I'm just going to take a look at some of the questions that have popped in. Given the fact that I've been to law school, I'm just going to take the one here on the liability system here. And Leslie, I'll go with you if that's okay. So the question is, what changes in the malpractice system could transform patient safety, and obviously some of this work here?
I think a couple things we should think about is learning networks, even on the malpractice side. And I am seeing that, though I'm new to the malpractice side. I was chief quality officer at Cleveland Clinic until about 6 months ago. So, or I guess now it's been a year, but really seeing them take the effort of proactive prevention versus just that kind of event happens reactive approach to that malpractice lens, which I love. And that's why I'm actually doing what I'm doing, because there's a lot of work that can be done there. And what I'm seeing is the malpractice kind of companies are getting together for learning networks, much like we've always done, or somewhat always done on the professionalism side. So it's been really nice to see them coming together and say, how can we learn together from the claims and the events we're seeing, what patients are telling us from kind of the tip of the iceberg. So learning networks are kind of up and coming for us.
Can I ask another follow-up question? So once we were talking to malpractice folks about why is it that there isn't more funding for innovation to decrease malpractice lawsuits and so on and so forth. And somebody basically said, well, if there are more malpractice lawsuits, we'll just charge higher premiums, like as an insurance company. And I just wonder, who actually has the incentive besides the patient to fix stuff, right? Like, do malpractice insurers really have the incentive to fix stuff, or is it too balkanized the way the financial structure works?
It's a really great question. I think it depends what malpractice insurance company you're looking at. I can tell you the one I work for is non-for-profit. We're owned by healthcare systems, including Johns Hopkins, so it's a pass-through. It's a non-for-profit, so everything that we collect in premiums, it goes to either help them out, and if they have a great year at the end, it flows back to them. But we do invest in patient safety projects and systems and strategies to help them. That is different than a lot of systems, though, typical malpractice insurance companies. So the incentives are more aligned in some arenas, and you'll see that in a few pockets. Otherwise, they're not as aligned, and you described it perfectly.
And I can share an anecdote as well related to this. I do think, obviously, healthcare systems have an incentive to reduce liability and to make improvements. And one of my roles prior to coming to ARC was at the University of Pennsylvania, being vice chair of quality and safety in the Department of Medicine. And we had a really interesting program over many years where we would make a plan every year around malpractice risk reduction. They were all safety, quality type projects and goals. And if we met those goals, we would get money back from the insurer. And so that oftentimes allowed us to invest in our staff, invest in our data analytics, invest in the further work we did. So it was a real win-win for us.
All right, so let me take the next question here, which I think is one that I think many of us who work in healthcare systems really feel, which is we see a lot of healthcare systems today trying to grow. There's a lot of pressure on them. They feel like they need to be bigger. At the same time, they're also feeling a lot of financial strain from reimbursement. And I'm not going to argue that these are two important things they need to tend to. But I think what a lot of us feel in the process along the way is that the prioritization of what they're focused on, safety or quality, may not always stay up as high as we'd like it to. Of the levers that we looked at today, I'd love to hear from all of you on how do we help get that prioritization back? as they need to grow sometimes and need to think about the financial pressures.
So I think that I'll use a sports analogy. You know, when you look at a scoreboard, whatever the sport is, football, basketball, doesn't matter. You can easily and very simply know when you're winning. You can easily and simply see that I've got a higher score. You know exactly how many downs you have or what quarter it is or how much time you have left. The challenge we have is that I think for a lot of hospital systems, it's hard for them to know and measure that I'm winning because we have so many metrics there. We're looking at so much data, but we don't have a way of saying we're now winning. And when we're winning, that means where did I include patient-centeredness? Where did I include safety? How do I actually define measuring quality, right? That's one of the things I think that we have to, if you're talking about how do I expand the hospital's footprint, how do I grow, how do I keep these prioritizations, it's knowing that you're winning. It's having that metric, that rubric, that scoreboard that can clearly and very simply show me that I'm winning.
But I'm going to push back just a little bit. It's not even pushback, because I agree with you. Let me be clear. But isn't that what CMS star rating is supposed to do?
Don't get me in trouble. Yeah. Yes, it does. Yes, it is. But I think that there are still gaps and seams in the star ratings, right? And so when you go back to the genesis of how those star ratings were made, how focused was it on patients? How focused was it on my experience and the things that I value most? And so this is where I think that as that hospital is trying to grow and continue to keep that prioritization, again, as I said earlier, you know, medicine is a people business. Understanding, like, when I go to the hospital with my son, 12 years later, it's a significant emotional event. Every single time I go through those sliding glass doors, it's a significant emotional event. You see the hospital every day. I go when he's sick or when I'm sick. And that's it. Significant emotional event. So when you kind of keep that as your guiding light, your North Star of I need to be patient-centered, I need to be patient-focused, I need to understand this is not normal for them, and then you put that into this metric or this rubric, and I'm like, how are my associates engaging patients? How are we trying to make this experience better? How are we trying to make care safer, more inclusive? That's how you start to grow. That's how you keep the first things first.
We have time for a couple more from the audience. Are there any that I missed that people want me to make sure I get to, or as I will come from here? A lot of good questions in here. How do we incentivize researchers to make sure that the data we need to kind of go scalable or that will prove value in what they've done is there?
How do we incentivize researchers that?
Right, to build their studies and analyses so that we know that there will be value in scaling it, and that there's value, that there will be value in the outcome that they've determined to be beneficial.
I may try and answer that one
Okay,
first,
please.
Alan,
Okay.
if you don't mind, just to sort of share, you know, some of the discussions at a high level that have occurred across the federal government. So obviously a lot of the grant proposals that are submitted are being responsive to how those grants are reviewed and scored by peers. And so if there are changes that we want to see in proposals, we need to change the criteria by which they're judging them. And we've had a lot of discussion around how actionable the findings of the work will be, how scalable the results of the work will be, and how to better incorporate that into the peer review so that those projects that are more pragmatic and more generalizable will rise to the top.
Great answer.
So from my perspective,
Your mic.
there are a few things. So in terms of incentivize and getting motivated, I am very motivated. So there is no problem in that, okay? The motivation and incentive is there. And most of us who is doing this work is also, I think, is incentivized, motivated to save the world, right? But what are the things that are missing? I'm sure researchers have their own limitations, etc. But some of the things are, some of it David also mentioned, we are just by design of the system, and some of it due to grant, soft money things, some of it because in the healthcare systems that we are working on, even embedded, we have hard time sometimes getting access. You know, if I am even within Hopkins, sometimes have hard time. Think of a researcher who is not even embedded within a large health system. So I think researchers, research part shouldn't be seen like as a secondary thing. Understand patient safety, patients are important, but in the long term, if we want to change things, research should be part of the operations, or they need to be talking more hands in hand. And there needs to be, I mean, this is not easy to do. There are many barriers. But that is one of the ways, I think, because the more I am friends with my clinician friends, you know, frontline, the more I am closer to the frontline and the more valuable research ideas we are coming up with in terms of co-design, etc. So that is number one, part of it. So we need to also, and clinicians are very busy, so we need to figure out how we will have more time of clinicians talking to more researchers, etc. That is one. Another piece is you do a study, it gets funded, 2 years later the focus changes. Now you need to find another interesting idea to fit to that grant. And then that grant ends, there's a new focus on a new grant. Then 10 years later, they start funding this 10 years old idea again, which happened to me. So you open that other grant, I save these all in my computer. So that is another thing. And maybe with philanthropic money or foundations, maybe there can be some continuation of a program, a research program on one bigger idea. Or two big ideas, that kind of thing that supports researchers, rather than me trying to think of where I will find the next money to put bread on my lab's table, so everybody will still have a job and do research. So that is, I think, the second part. Thank you.
Wonderful. No, thank you. Did you want to add a little bit, Craig?
I may add one more quick element. Something that I've seen be very successful at AHRQ in my time there is having requirements about who is not only on the research team, but who are the co-PIs. So for our patient safety learning labs, you know this well, it needs to include a human factors or systems engineer. For some of our learning healthcare system K awards, you need to have healthcare administrators as part of that research team. So having those requirements and thinking about, you know, who needs to be included for that work to be sustained and valued, I think is important.
And may I say one more thing?
As long as you pick up your mic.
Yes. I mean, NIH cap, I'm not going to complain about people, how much salary we are all getting paid, but NIH cap, finding a radiologist who will accept to work at that rate isn't that easy, right? So that is one of the other incentives. I mean, I can find internal medicine, I shouldn't say that, but internal med-doc, geriatricians, but radiology, etc. So we need to think about, that is the reality. Why will they spend time basically talking with me other than they are really interested in research, etc., rather than making more money at that 1 hour, next 1 hour?
I think just one other thought, building on what Craig said, this sort of idea of broader engagement on the team, stakeholder engagement prior to proposal preparation, some of the things that PCORI has really implemented in their architecture as a means of ensuring that not only do you design the right study, you know, to benefit the stakeholders involved, but you also have the right combination of people available to be able to implement or disseminate or scale. I think that we could probably do a lot more of that with some modest changes to the review process, but it's not just the review criteria, it's the reviewers. So you can change the review criteria, but if the reviewers still think that it's, oh, this is just a renaming of all the stuff that I thought before, and this is the way I approach the problem. Like, I think we need to, not to be too much of a troublemaker and throwing hand grenades in the middle of stuff, but I think we kind of need to blow up the review process a little bit. I think we should be doing much more like some of the foundations do. The Gordon and Betty Moore Foundation, I thought, had a great approach where you'd send sort of a 2-page précis, this is kind of the big picture. They say, we like it or we don't. If we like that idea, I'm going to sit down with you, and we're going to work on it together. And if we can come to some sort of understanding and agreement about the scope and the scale and the type of thing, we're going to fund it. But we're going to co-produce that with you. I think we just need to be closer to that with all the federal funding. Skip it. I mean, what is this? You lob it over the fence, and then 9 months later they say, thumbs up, thumbs down, and then you lob it over the fence again, and 9 months later they say thumbs up or thumbs down. It's awful, right? And it slows the whole process of innovation down, and it's not really the right thing. You should, get a simpler idea out there, then have an interview, 30-minute interview with the panel or whatever.
So along those lines, because we're almost at time now, so just in 1 minute or less, I'd love to hear from one or all of you or some of you. And Cindy and I had a chance to talk about this. Again, I'd argue the Doris Duke Foundation had a good funding process for this meeting, right, at the end of the day. So thank you again. And what we were talking about is that this was meant to be a conversation that they wanted us to start. What I would love to hear from all of you is, what do you think would be a good, tangible next step?
We can submit.
Marty can respond. How about that?
No, let me take it first. And if there's time, only if there's time.
I think today, the morning was great. We really got a lot of new ideas from shifting who talks to who about what around specific themes. But this afternoon, I really wanted more time to reflect on what I'd heard. So I think, even though I know this is hard and it costs more money, just another half day of this so that we can think about what came out of it. I think in our group this afternoon, we were still groping around what the right strategies were. David, you seem to be crisper in your group. Our group was still groping around, what our strategies were, and we just needed like another few hours. But that's my comment.
Dana, did you want to say something? Was it you? Yes?
It was me, and I would be remiss if I didn't just tag in very quickly on the question about the MPLs, the medical malpractice insurance companies. And I do think there's a long history and a belief, in fact, that universally we're not as invested in the frontline patient engagement, delivery of patient care for years, and that the response was on two sides. One from the organization, that's what I pay my malpractice insurance for. So if I have a bad outcome in OB or an ED failure, my insurance company will cover it. And from the insurance company, there was the sense that, of course, if your loss ratio went up, that we would just increase your premiums. Absolutely true. However, the market is changing drastically. There is so much consolidation and acquisition in the MPL market now that the business has become a business in a way that we need to be invested in the entire package. Many people know that I worked for Crico for almost 20 years, and 100% of their focus and investment, and in fact the leads of their delivery of service, was focused on engaging their shareholders in patient care initiatives and endeavors. Recently, I switched to the commercial insurance industry, and I was surprised at first that it wasn't led as strongly by their patient safety leaders. It was more the business, right? What the premium is. But we're learning that if we don't start managing our premiums, we are in fact going to lose business. And each of us is already struggling to maintain our business. We do want to be at the table. We need to be at the table. We need to involve the ROI of the medical malpractice insurance industry in the equation of saving dollars and improving healthcare in the end. Because we are paying more and more premiums. We want to be, we have knowledge, we have data, we have investment, we have risk managers, we have experience, but we haven't found a way to get to the table because we're viewed as big brothers watching. I don't want to invite them in. So I just want to make a public statement that from the MPL industry, invite us in.
Perfect, thank you for that. Any other thoughts here? Greg?
I think what Doris Duke has done with this series of discussions has been wonderful, and it's great that there have been discussions around patient safety. I know just from speaking with Cindy and her team that a lot of their goal is to spark not just discussion but action with the available dollars that they have. And one of the threads across all three safety areas that I saw today was this idea around what is the return on investment and making it tangible. So you could imagine a foundation like Doris Duke funding a series of initiatives where you take, some of the potentially most impactful safety efforts and develop tangible ROIs that could be used, by healthcare systems to make an argument for investment. So that could be a next step.
Wonderful, thank you. So I want to keep, David, did you want to sneak? Did you both want to? No? You guys good? Okay.
No, I'm good. I'm gonna let it.
Just very quickly, I think there are two levels here at which this question can be answered. It's the level of what can we as a field do as our next steps out in the world, and there's what can this group do to kind of facilitate that at a
The latter one that I'm asking. Yes.
meta level. And I think the answer is we can find a way to motivate around a shared set of things that we can agree we want to implement in the world, because it's the it's the old I think it's an African proverb about if you want to go fast, go alone. If you want to go far, go together. And that's really what we need to do. We have to find a way, whether it's just a willingness to accept that, for example, our pet thing might not be the one, specifically chosen project, but the more you can boil it down to, 1, 2, or 3 things, not more than 3, the closer you are to being able to actually get it done.
Thank you for that. Yeah, so we're going to have more time at the reception. I would encourage anybody, if you have more ideas, to you can bring them to me, you can bring them to Laura, you can bring them to Marty. We'll be happy to take them on what you think would be good, tangible next steps. We're obviously going to think about it and bring it back. But I got to tell you, I tend to agree. We were talking a little bit about this earlier. It's how do we figure out a way to work together to drive us forward, right? And that's the key here, and I would love for everyone to think about that. And again, I want to thank you all for just an absolutely lovely day, great conversation. We've got an incredible level of talent and expertise in this room, and you can see it from the discussions that we've had in the panel that we just had. So can we take a moment to thank the panel as well? And I will now turn it over to Laura and Marty for the last few closing comments.
Thank you so much, Alan, and to all the panelists. That was really a fabulous discussion. And thanks to each and every one of you for attending and for your energetic and robust participation today. Thank you again to the Doris Duke Foundation for the generous support to make this day possible. Kevin, Cindy, it was delightful to have you here. Marty did bring up some next steps. You should expect to hear from us in the next few weeks with an email discussing what the findings were and what next steps we might take. This poll is also still open. Should you wish to provide some feedback there, we would very much welcome that. I want to take another minute just to recognize Allison and the facilitators who have done such a fabulous job of crafting this day and really bringing it to fruition. And the many, many people who have helped get things done at the last minute to make this day so great. There will be boards up. The boards from the day will be displayed upstairs in the hallways. So as we go up to the reception, feel free to take a look at those. We will be taking photos and saving them. And thank you to Marty for co-hosting.
Well, thank you for giving me a great experience working with this fabulous team and putting this together. I really appreciate it. I'm very cognizant of all the people who wanted to be here that couldn't be, so I think the follow-up is important. I couldn't agree more with you, Alan, about this was the start of a conversation that really needs to be continued. It's a rich start, and I think it will get better as we go forward. So having a good process to share what we got out of today with people who can help us get to the next steps, I think is really, really important. And I couldn't be more grateful to the funders, again, for making this possible. So thank you very much.
At that, I think we have hopefully held off the rain that might have been predicted today and can go upstairs and enjoy the roof deck reception. Thank you.
Oh, really? Oh, sorry? Yeah.